and share a great case from the ER that I had worked with one of my students to write up, Anna Martin, and currently in the process of editing. So I look forward to presenting this to you both. So the case title, and I'll let you take it from here, is a 31-year-old male presenting with headaches and dizziness. And he was whisked back from the urgent care section for a bed because of this complaint. And that was the first aliquot.
Wow, what a start, Travis. Just your cases never disappoint. So this is like a relatively young man coming in with headaches and dizziness. And again, like most often things, the tempo, it's very informative, whether this has been happening for days, weeks, or is sudden onset. And the thing about headache that I think we always talk about, similar to like diarrhea, is it a primary or a secondary etiology? While the headache is there, like my focus initially was probably on dizziness to get a better sense of whether it's peripheral or central. Like in most in all comers, like a peripheral causes, especially PPV is the most common. However, you want to like make sure to think about mostly central causes and most sinister causes. Like posterior stroke is one of the known misdiagnoses. However, like in a 32-year-old, that would be odd. However, like dissection, like vascular abnormalities in the younger folks, congenital issues might be at play here. My thing is like to get a good history, a good exam. Hence, the exam can be really helpful here, and go from there. RG, what are your thoughts?
Control C, Control V, enter. Those are my thoughts. I couldn't agree more. Spot on. Travis, give us more, please.
So he is coming in with about 2 weeks of symptoms where he notes headache, feeling weak, and dizzy. That started, has gotten progressively worse. He's noticed it more when he's outside working. His dizziness, he describes as not room spinning per se, but more like lightheaded when he stands. But this is kind of how he describes it, probably with 80% of the population. When they describe lightheadedness, they say dizzy. He says it improves with sitting and better in rest. His headache is worse outside in the light. It's not preceded by a visual disturbance. He notices it more at work when he's outside. And he noticed some nausea and vomiting and fatigue with it as well. He denies a prior history of headaches, recent falls, recent trauma. He denies any fevers, night sweats, or weight loss in the past 2 weeks. He denies any double vision, dysarthria, numbness, or weakness in any of his extremities. He doesn't note any abdominal pain, urinary symptoms, changes in bowel habits, melena or hematochezia, denies any rashes or joint swelling. He has an unremarkable past medical history, does not abuse any drugs or alcohol. He has an unknown family history. His medications that he takes, he's just been taking Tylenol here and there, but he finished a course of amoxicillin that he took for about a week to 10 days. He's not sure, for a dental infection prior to the symptoms starting. He works as a painter. He previously worked in agriculture, and that's the end of this aliquot.
Absolutely, very intriguing. And maybe I can tackle the additional foreground data that you gave us, and then pass the background data to Charmaine. And I think that the data that you gave us is dancing between so many different things. Just to focus on the headache for a second and tackle the harder topic later. The characteristics of the headache that are concerning is that it is new, the patient hasn't had it before, and it's persistent. So 2 weeks of a headache syndrome is virtually incompatible with a primary headache syndrome if the headache has been persistent. So things like tension headaches, trigeminal autonomic cephalgias, and migraines usually remit, or at least at maximum within a week. Now, there are exceptions to that. There's status migrainatus, for example, which is a persistent migraine that lasts for a long time, but that's a diagnosis of exclusion. So the headache we have to put in the likely secondary bucket, at least for now. And that's further amplified by the possibility that there might be photophobia. And that photophobia is implied, though not definitively confirmed by the prominence of the headache outside. And so that photophobia in the context of the headache would have us worry about meningeal irritation, but that's not the only overlap. You can get photophobia and a headache with a concussion, for example. And you can definitely get photophobia and a headache with ocular complaints like acute ankylosing glaucoma or uveitis or scleritis. So it's hard to be sure where that photophobia maps onto the eye or the brain. However, the eye is less compatible with the rest of his complaints, the dizziness. And so analyzing dizziness reminds you that the language that we have in English specifically makes it impossible to make definitive progress with trying to reformulate the word dizziness into another word. You're really going to struggle if your goal is to translate dizziness into lightheadedness or a disequilibrium. Instead, you should try to invest your energy in another task. And that task is whatever they say, your patient says, is it continuous, independent of a trigger, or is it brought on by a trigger? So if I tell you my dizziness only happens when I move, that's a provoked dizziness. If I tell you that my dizziness is horrible no matter what, then that's continuous dizziness. That distinction is much more diagnostically fruitful than trying to elaborate on whether the dizziness is lightheadedness or not. So here the dizziness seems prominently provoked, and it's provoked either by standing or moving, which limits the differential diagnosis significantly, primarily to peripheral causes of vertigo like BPPV, or orthostatic hypotension from a cardiac or hypovolemic cause, or the rare causes would be things like CSF hypotension, so low CSF pressure, which would cause headache and dizziness worsening upon standing, and the certain effects of toxins, which we won't elaborate on now. I would say that the foreground data is concerning regarding the headaches and is suggesting a provoked dizziness syndrome, and we'll open up and expand those threads when we get more information, but the background may be helpful too. All right, Mike, to you, Charmaine.
Oh, that was so beautiful, Archie. I think in terms of the background, the one thing that just catches my eyes is a dental infection that he got 7 to 8 days of antibiotics for, mostly because, if you worry about like orthostatic hypotension, is that underlying infection that is now metastasized? If you think about meningeal irritations, although that would be a little odd. However, like a disseminated infection can make people feel very sick, dizzy, not well. But other than that, I think an exam would be really helpful.
All right, you ask and you shall receive. So physical exam, oral temperature 37.4 Celsius, heart rate was 74 beats per minute, blood pressure was 111/48, respirations were 20, O2 sat 98% on room air. General, he was alert oriented, no acute distress. His HENT exam, he had notable conjunctival pallor without icterus. He had some poor dentition with multiple dental caries. He also had a isolated small lingual ulcer that was about 0.5 centimeters just left to the midline on the distal aspect of his tongue. His neck was supple, no JVD, no lymphadenopathy, heart sounds normal, no murmurs, rubs, gallops, no pedal edema. His lungs were clear, no adventitious breath sounds. His abdomen was soft and untender, no organomegaly. Skin was pale without rashes, petechiae, or purpura. Neuroexam was normal. And that's it for his exam. A CT scan was ordered prior to him coming back, just because of his complaint. And it was read as that was a CT head without contrast, was normal. And I probably, let's see how much time we have. You want me to give you the first run of the labs right now? Does that work? Yeah, okay. Because we're all palm readers here, we looked at his palms and we noticed pallor. His hemoglobin came back at 3.9 grams per deciliter. His white count was 2.0. His absolute neutrophil count was 0.2. His hematocrit was 11.4. His platelets were 28. His retic count was 29, which is just under the lower limit of normal from 30 to 170. His MCV was elevated at 109. The RDW was 18.4. His chemistry panel was normal. Everything on there was within normal limits, from the sodium, potassium, chloride, bicarb, glucose, everything was normal. Kidney function, creatinine was 0.8. And LDH was mildly elevated at 245. Add on the total bili was normal as well at 0.9. Haptoglobin was normal at 128. Alk Phos was normal at 77. AST and ALT were normal, and an INR was 1.2. So that is the end of this aliquot. And if any labs didn't get put on there, I can post them.
RJ, I think it's very fitting that for the last one we have to talk about pancytopenia again. We're coming full circle. I'll let the incredible RG go through the labs, and just to think about the exam and the vital signs. Medicine is so humbling and human body is fascinating, right? Look at those vital signs. His blood pressure is within normal. He's not tachycardic, although he's probably in a sitting position. I have a suspicion that if you have to walk him, he probably is going to become more tachycardic. And his oxygenation is completely normal, and yet his hemoglobin, he's pale, and his hemoglobin is very low. And that tells you something about the chronicity of this. If somebody acutely drops their hemoglobin that much, like your body is not going to have a chance to be able to compensate as well. So it tells me that this is something that is happening for a while. The one thing about the exam that I'm just noting, but I'm not going to invest that much diagnostic of my cognitive my on it, is the ulcer. I will compute, to be honest, I'm not sure if that's noise or signal. We can, with the ulcers, it can be something to the local environment, autoimmune diseases, infections that can do it. However, I'll just keep tracking it to see what the rest of the data shows, to see if it becomes more relevant or not. And, you don't see any big ecchymosis. Again, you just want to make sure, although our suspicion is lower for an acute anemia, but making sure there's places that you can hide blood, like your thighs, retroperitoneum is just harder to assess for lungs, those GI tract. We don't have anything from the exam that notes to that yet, but something to investigate further. RZ, take it away.
It's incredible. You know what? I've actually refrained from doing this, but I think we should do it today. The reason I refrained from doing it is because I think pancytopenia is really, really hard, and different people have different approaches. But let's take a minute to try to make it clear to all of you. I think it's a mistake to have an approach to pancytopenia, and I think Charmaine and I have many stories to tell you why. Just like it's a mistake, Aaron will tell you it's a mistake to have an approach to weakness. You should first try to clarify what is the nature of the weakness: bilateral, unilateral, low reflexes, high reflexes with sensory symptoms. So you should be in information gathering mode when you see the word pancytopenia. You should not try to solve the problem. Okay, so that's my first piece of advice. So you have to try to put it into one of three boxes. And the pancytopenia is either because you are losing all your cells in the periphery. The best example of this is lupus with autoimmune pancytopenia. Okay. The other category is impaired hematopoiesis, where the stem cells are not turning into the cells they need to be. And the last category is myeloptosis, where the bone marrow is failing because of an infiltrative disease process coming from outside the bone marrow. These are the three categories that then have very simple, easy to follow approaches to. So the real journey in pancytopenia isn't finding the answer. It's finding which of the categories are at play. There's a simplification here, which is the assumption that a patient only has one mechanism of pancytopenia, which is what Hans, Kirtan, and Ravi taught us on Wednesday. That's not true. PNH, for example, has a combination of increased loss and impaired hematopoiesis. But you start off by trying to simplify it. And you have three tools that are readily available for every single patient. That's the time course, the center of gravity, and the peripheral smear. Now, the time course may be unknown, but can be assumed based on the duration, based on the prominence of symptoms. And to answer Hans's question, you don't have a bone marrow at the time that you're making this analysis. If you have a bone marrow, you need this information to decide whether you should or should not get a bone marrow. So yes, Hans, you need a bone marrow to answer it, but this is helping you ask the question, do I even need a bone marrow? And so let's play the game here. I will say that what Charmaine said about the vital signs tells you what the time course is. This is not acute. So immediately, increased loss causes are much less likely. The center of gravity of this disease is the pancytopenia. We haven't heard about anything else, right? The bone marrow is the center of gravity. We haven't heard about fevers, splenomegaly, lymphadenopathy, pulmonary disease, so on and so forth. So the combination of the subacute to chronic time course and the lack of any signal elsewhere prioritizes the mechanism to be impaired hematopoiesis. And that's supported by the macrocytosis that Ravi pointed out in the chat. And so we are asking really the question of why does this patient have impaired hematopoiesis? And the way we go about answering that question, and you see, by the way, the other clue for impaired hematopoiesis, you see this? Patient also has this. So I will just leave it at that I think the pancytopenia here is suggestive based on the time course and the center of gravity that the patient has impaired hematopoiesis. Of course, this is a suggestion that you should prompt a specific workup. And if that workup doesn't lead to the answer, you should reassess how you did this because it's not definitive. And now, what causes impaired hematopoiesis? Either a deficiency in the raw materials or a problem with the stem cells. The patient has no risk factors for deficiency of raw materials and has a prominent risk factor for an issue with stem cells, and that's his toxic exposures. So whenever you hear a young person with toxic exposures, you think about aplastic anemia. The painting, the heavy metals are a red flag for that. That's a diagnosis of exclusion. But to answer Hans's excellent question, it pushes you to get a bone marrow biopsy in this patient. So this analysis says, hey, this patient has impaired hematopoiesis. I'm not finding a reason as to why they have deficient elements. So as Hans suspected early on, this patient probably needs a bone marrow biopsy at some point. Thoughts, Charmaine, before we pass the mic to Travis?
Just so glad you had to talk about pancytopenia today.
I know, right?
I'm happy. I'm so happy.
Alrighty, Travis. More.
All right. So for our last aliquot of information, so I have a folate level that was normal at 14.2, a B12 level at 258, kind of on the lower end of normal, but still within the normal range. On this lab value, 180 was the low normal. HIV test was negative. Hepatitis panel was negative. Parvovirus B19 IgG was positive. IgM antibody was negative. He did have an abdominal ultrasound, I think probably to look for splenomegaly and hepatomegaly, that did not show any organomegaly or any other evidence of malignancy. He did have a bone marrow biopsy, which showed markedly hypocellular marrow for age, no increase in blasts or plasma cells, and no lymphoid aggregates or granulomas. Flow cytometry was sent, and that was normal. So based on this information, a presumed diagnosis was made, and I can chat about it when you guys are finished. Or if you want me to tell you what the consensus was, don't mind that too.
I babbled so much, Charmaine. Please take it home.
Sounds good. I think like Robbie's analysis was just fantastic. So thinking about the raw material versus the stem cells, and I think like, you know, worrying about aplastic anemia, I think you potentially could fit with this presentation. And I think when I think about aplastic anemia, most often I think it's idiopathic actually, but you know, there are infections that you worry about, as mentioned before, with parvovirus. That was checked. I think CMV can do it as well. And then like autoimmune etiologies as well that we really haven't gotten a sense for it. The two cancers that I think about, one is like cancer of like older folks like CLL, and then like for younger for like thymoma is the one to think about. And as Robbie mentioned, like toxin exposures like benzene is a big one as well. And I'm like, I think it was organophosphate is something else to think about. So I think I wonder if the presumption diagnosis is aplastic anemia, and then whether it's idiopathic or due to secondary causes. I think is where the question is at. RG, what do you think?
Completely agree. I think it's very hard to tease that out. At the end of the day, the only causes of aplastic anemia that change your diagnosis or management are the genetic causes, and the way they change your management and diagnosis. You don't want a family member to be the source of your transplant because they likely have the disease. So the impetus for aplastic anemia is to really make sure that you've ruled out the familial causes. But after that, I don't think it's possible to definitively tease it out. And then just so we talk about it, I think the main DDX of this is hypocellular myelodysplasia. And the biggest clue there is the flow cytometry. In aplastic anemia, there's a paucity of stem cells. So the stem cells are absent. So you'll have very low CD34 cells. In MDS, the amount of stem cells is actually normal or high. So the CD34 cells will be normal or high. That's one helpful way of distinguishing aplastic anemia from hypocellular MDS. Though I don't know what the implications of that distinction is, because I think they're both treated similarly, but I'm sure at the level of hematopathologist, that probably matters. Travis, mic's yours, my friend.
Yeah, so he was diagnosed with aplastic anemia. He was admitted, he was transfused, some PRBCs. He did well with the transfusions, and his hematocrit and hemoglobin improved. He was discharged home without a diagnosis yet, but you know, we were able to follow up because he came back in for after his first follow-up visit to get another transfusion. So they presumed it to be from the amoxicillin that he took like for a week prior. And there isn't really much literature on it. I know someone shared in the chat about different, Robbie did, about some beta lactams and antibiotics. I want to say it's been seen with Augmentin, but you know, given that they didn't have another cause, potentially amoxicillin was the cause of it that he took for his dental infection. So that's what they were going on. He wasn't being treated for anything. They were just going to follow it, I think, for about 3 to 4 months to see if he would improve. And they suggested that he, just based on stats, I want to say they threw a number out, you know, 80% of people in this category, you know, will spontaneously recover, you know, withdrawing the medication and everything like that. So they were going to just monitor him and give him symptomatic transfusions. If he did need therapy, the therapy that they were going to put him on would be some immunosuppressive therapy, one called anti-thymocyte globulin, or ATG, along with prednisone. And I guess they use the prednisone to prevent serum sickness or something else like that. I think it's what we had looked up and found. And really, as far as his clinical presentation, so you know, he didn't speak English, and I speak poquito Espanol. And so I think, you know, his symptoms and his headache in the beginning, you know, they didn't, you know, if you like were to see him, you know, talk with him, I mean, his hands were just like pale white, and, you know, his headache and dizziness is all, he's out working in the sun, he's doing stuff, he's out working in houses. I mean, he's getting headaches just because he has no oxygen carrying capacity. And I mean, that's why he was feeling just so weak in the headache. So, I mean, I understand if you're out in the heat all day, you're going to get hot. If you have no hemoglobin, I figured you'd get the same symptoms. And then his hemoglobin came back and like, whoa, go figure. But like I always, I love the physical exam, looking at the conjunctiva and being a palm reader. And I always remember, Reza making a point about, hey, let's take a guess and see what your hemoglobin is by looking at your palms. And if you can tell it's likely less than 9, take some bets. We were off. I said maybe 5 or 6. I mean, he was 3. That was pretty low, but he's a young guy who compensated pretty well. But you guys nailed it. So
Travis, I think knowing what ERs are like in the majority of the country and knowing what yours is like, I'm just in awe of the fact that you can be so meticulous in your thinking and so thoughtful and your patient's care. And I don't know how many people who are as hectic as ERs have the bandwidth and the desire to follow up and learn this much. It's so palpable. If any of you have ever been to an emergency room, and I hope the contrast of the craziness of the ER, how hard it is to sit and reflect and learn about aplastic anemia, I think is really cool and very, very unique. So thank you for bringing that uniqueness here. We really, really appreciate it.
When you have learners, it makes it a lot more fun. It makes work fun. It makes your job fun. So you don't have to sit there and focus on, the things you can complain about. And I think it really makes medicine an enjoyable job to be at when you have people and learning. So that's why I do it.
Yeah, speaking of learners, I got to run to meet my learners in where I work. So a pleasure to see you all. I'll pass the mic to Charmaine to reflect finally, and the word to teaching points.
Thanks, Archie. Travis, you're so awesome. Thank you so much for always teaching us. It's always a pleasure. Thank you all. This was such a fascinating case. Deborah, do you want to take us home with the teaching points?
Hello, everyone. Great case. Awesome discussion. The chat was always on fire. And going for the teaching points, talking about headache, dizziness, and young patient, we got to think about the tempo, the type of headache, the location, and some causes that could be a posterior stroke. And the photophobia can be confirmed by headache, outside, amnesia, irritation, or ocular complaints. And you got to think if the pain continues, no matter what the patient do it, or is provoked by standing or moving. And in this case, the hemoglobin was very low and the body was not able to compensate it. And thinking about the differential diagnosis, we thought about autoimmune infections, autoimmune hemolytic anemia, intravascular hemolysis, intramedullary hemolysis. And the Pancytopenia, we thought about the 3 clues: the loss, the low hematopoiesis, and the myelophysis. And the plastic anemia, as Ravi said, could be by thyroid, beta-lactam, antibiotics, sulfonamides, and NSAIDs and anticonvulsants. So thank you very much. I see you all tomorrow.
Thank you, friend. Thank you all so much for joining us. Always a pleasure. Can't wait to see you all tomorrow. Bye.
Bye, everybody.